In the intricate world of ocular diseases, few conditions are as elusive and intriguing as presumed ocular histoplasmosis syndrome, or POHS. Presumed ocular histoplasmosis syndrome is typically associated with endemic regions like the Ohio-Mississippi River Valley. Though well documented in the West, this syndrome remains a rare clinical entity in India, often overlooked or misdiagnosed. POHS is characterized by a triad of distinctive clinical features: peripapillary atrophy, punched-out, chorio-retinal scars scattered across the posterior pole, and the potential development of choroidal neovascular membranes. Notably, there is an absence of vitritis, an important clue that helps differentiate POHS from other inflammatory conditions. The diagnosis of histoplasmosis is usually clinical, as serology and other investigations are not conclusive. But what happens when its signs appear in a patient from India, a non-endemic zone? A series of 3 cases from All India Institute of Medical Sciences has described the presence of POHS in India. In this compelling case presentation, we explore the diagnostic journey, clinical findings, and management of POHS in an unexpected setting. 34-year-old female presented with a 1-week history of sudden-onset blurring of vision in the left eye. Best corrected visual acuity was 6/6 in the right eye and 6/9 in the left eye. The anterior segment examination was unremarkable in both eyes. Fundus examination revealed bilateral peripapillary atrophy with multiple punched-out chorio-retinal scars scattered across the posterior pole. In the left eye, a juxta-foveal choroidal neovascular membrane, CNVM, was noted. The vitreous was clear in both eyes, with no signs of inflammatory activity. OCT and OCT angiography confirmed the presence of CNVM in left eye. Patient was started on oral corticosteroids and was advised intravitreal injection of ranibizumab, which she underwent on 14 February 2022. 1 week following intravitreal injection, the choroidal neovascular membrane showed signs of regression, and the patient's visual acuity improved to 6/6 in the left eye. She was advised to remain under close observation, with the possibility of additional injections based on future activity. Unfortunately, she was subsequently lost to follow-up. 1 year later, the patient returned with complaints of progressive visual decline. In the interim, she had received multiple intravitreal injections of ranibizumab and Ozurdex at another center. On examination, there was evidence of recurrent choroidal neovascular membrane in the left eye, accompanied by an increased number of punched-out chorio-retinal lesions, suggestive of progression in presumed ocular histoplasmosis. Recurrence of the choroidal neovascular membrane was confirmed on optical coherence tomography and OCT angiography. The patient was advised to continue intravitreal anti-VEGF therapy. Unfortunately, she was lost to follow-up thereafter. Though rare, presumed ocular histoplasmosis syndrome can occur in non-endemic regions. Clinicians should remain open to its possibility even outside traditional geographic zones. Clinical examination and a high index of suspicion are critical for diagnosis. Characteristic fundus findings and exclusion of other causes can guide. Choroidal neovascular membranes in POHS respond favorably to anti-VEGF therapy. Timely intervention can restore and preserve visual acuity. Long-term monitoring is essential. Recurrences may occur, and patients should be counseled on the importance of follow-up.